All right, we're now talking about section 5, the spinal nerves for the spinal cord for chapter 14 for A&P, and we're now going over objectives beginning with you should be able to, at this point, after going through this section, for each spinal nerve except C1 and CL1, beginning and the end, essentially, identify the opening where that nerve exits from the vertebral column, compare and contrast the anterior and posterior rami of a spinal nerve, define a dermatome and explain its clinical significance, define a nerve plexus, identify the distribution of intercostal nerves, list the nerves of the cervical plexuses, explain the action of the phrenic nerve, explain the structure of the brachial plexus, including the 3 trunks, 2 divisions, and 3 cords, describe the distribution of the 5 major nerve branches that arise from 3 cords. You should also be able to identify the spinal nerves that make up the lumbar plexus, compare and contrast the femoral and obturator nerve composition and distribution, list the spinal nerves that form the sacral plexus, describe the composition of the sciatic nerve, and compare its branches. So with the general distribution of the spinal nerves, after the invertebral foramen, the spinal nerve splits. With the posterior ramus, basically it's a small branch, it innervates the muscles and the skin of the back. The anterior ramus is a large branch. It splits into multiple other branches. At different levels, this ramus innervates the anterior and the lateral trunk, the upper limb, and the lower limb. It participates in plexuses, and the rami, or the rami, or rami communicantes is a small branches of autonomic fibers. It extends between the spinal nerve and sympathetic trunk ganglion. And the ganglia is interconnected in a sympathetic trunk parallel to the vertebral column. So here we have our body of our vertebra, and then we have basically this rami communicantes and sympathetic trunk ganglion here. Here's a spinal nerve, and basically we have all these spinous processes, of course, coming through here, of course, this vertebrae. We have the deep muscles of the back, right here, and the posterior root, which is right in here. We have our posterior root ganglion, and we have our anterior ramus, and their anterior root here. I think we got them all. The dermatomes for the spinal nerves, the segment of the skin supplied by a single spinal nerve. Some overlap in innervated regions, like T10 dermatome is the horizontal ring of skin around the umbilicus. It can help localize damage to one or more spinal nerves, like the loss of sensation on the medial arm, and the forearm indicates C8 damage at C8 cervical 8. It's involved in referred visceral pain, like an appendicitis, which is often referred to the T10 dermatome. So here we are dermatome maps, which we'll talk about a little bit. It's pretty cool how each one of these areas specifically shows exactly where they innervate, which each nerve all the way from basically C1, go up here, C2 actually shown here, all the way down through S1, down to the bottom of the body. Pretty cool. For clinical view, for shingles, you're not going to have to know all that, by the way, all the dermatomes, exactly which one innervates where, at least not right now. For shingles, basically for future, and the importance of recognition and application as always, is the reactivation of the chickenpox infection. At this point, if you supposedly should have had chickenpox, because of course as we get older, it gets more and more severe. Some diseases are more difficult when you're older, and some are more difficult when you're younger. And chickenpox, one of those specifically, is more difficult when you're older. The virus remains latent in the posterior root ganglia, and when it's reactivated, it travels through the sensory axons to the dermatome. You get a rash, you get blisters along the dermatome, and you only get it in a specific area. So when you go back to that little dermatome picture, so specifically whatever area is innervated or affected, that's the area where that rash appears. And you may only get it in very specific areas, whether you're talking about chickenpox or shingles. Since the reactivation, of course, we're talking about shingles. Burning and tingling pain, also antiviral medication can reduce severity, and there's a vaccine, of course, to prevent or reduce disease severity. Our nerve plexuses now. The network of interweaving anterior rami or rami of the spinal nerves. The 4 main plexuses occur bilaterally: cervical, brachial, lumbar, and the sacral plexuses. The most thoracic spinal nerves, or most thoracic spinal nerves, and nerves S5, sacral 5 to basic coccygeal 01 do not form plexuses. The individual rami branch repeatedly. The damage to one nerve or spinal segment does not deprive a muscle or skin region of all innervation. So the intercostal nerves are located between the ribs. We got the anterior rami of spinal nerves T1 to T11. T12 is a subcostal nerve inferior to the ribs. T1 anterior ramus, which part goes to brachial plexus, that part goes to the other part goes to the first intercostal space. T2 anterior ramus innervates intercostal muscles in the second intercostal space, like along your ribs. The receives sensory information from axilla and the medial arm surface as well. And the T3 to T6 anterior rami innervate the intercostal muscles also. They receive sensory signals from the anterior and lateral chest wall. And T7 to T12 anterior rami innervate intercostal muscles and abdominal muscles. By the way, you're not going to know all of these for your exam. This is something that you need to recognize how the intricacy, of course, like so many things, of their involvement, the intercostal nerves in this case. And of course, they receive sensory signals from overlying skin. You will have to understand the basic structure, though, for sure here. So we have our intercostal nerves here with our sympathetic trunk, whole area right through here. We have our spinal nerve and the posterior ramus. And then we have the anterior ramus coming along through here, and the intercostal nerves. Okay. We have our posterior root and our posterior root ganglion. And we'll get a little closer for that. So posterior root ganglion and posterior root, our anterior root, rami communicantes here, and a sympathetic trunk ganglion. And the cervical plexuses, the anterior rami of C1 to C4. C5 contributes a few axons. Branches innervate the anterior neck muscles, the skin of the neck, and the portions of the head and shoulders. We've got our 5 basic plexuses, and this is the first of them, the uppermost, the most superior. From rami of C3 to C5, it gives rise to the phrenic nerve, innervating the diaphragm. So here we have our cervical plexus, a little better image here. We have our hypoglossal nerve here, which is basically our cranial nerve we talked about before, which is basically CN12. Our accessory nerve, CN11 here. Our segmental branches, C1, C2, C3, C4, and C5 through here. Or C1, 2, I should say here, our cranial nerve 1, 2, 3, 4, and 5 there. Okay, our 5 here. And I said the branch of the brachial plexus here, branching out here, that's C4. And the supraclavicular nerves here, our phrenic nerve, it's a big one here, coming out here basically from our C3 here. And we have our lesser occipital nerve here, and we have a greater auricular nerve, our transverse cervicular nerve, the ansa cervicalis, which is superior root, and our inferior root as well. We got them all there. Of course, atlas and axis being C1, C2, these are vertebrae, not to be confused with our cranial nerves here. And eventually, of course, they branching out and affecting our other cranial nerves as well here with C12, with our CN12 and our CN11 here. Our brachial plexuses, they form the anterior rami of the C5 to T1. So we're going down, right? The network of fibers extending laterally from the neck into the axilla that compose the anterior rami, the trunks, divisions, and the cords. The rami unite to form trunks in the posterior triangle of the neck. Superior trunk from rami of nerves C5 and C6, middle trunk from the ramus of nerve C7, and then inferior trunk from rami of C8 and T1. The trunks divide the anterior and the posterior divisions, and the axons innervate the anterior and posterior parts of the upper limbs now. These divisions converge to form cords near our axillary artery, with the posterior cord formed by the posterior divisions of the superior, middle, and inferior trunks, contains portions of C5 to T1 nerves. The medial cord is formed by the anterior division of the inferior trunk, and it contains the portions of the nerves C8 to T1. And then the lateral cord, which is formed from the anterior divisions of the superior and middle trunks, contains portions of nerves C5 to C7. And these cords give rise to 5 major terminal branches: our axillary nerve, our median nerve, our musculocutaneous nerve, our radial nerve, and our ulnar nerve. That axillary nerve is going to go to the deltoid, the shoulder, teres major muscles behind, sensory input for the superolateral arm. The median nerve is to the most anterior forearm muscles, the thin arm muscles, the lateral lumbricals. This basically is sensory input from the palmar side and dorsal tips of most fingers, not the pinky though. The musculocutaneous nerve is to the anterior arm muscles like the biceps brachii, with sensory input from the lateral forearm. And the radial nerve is the posterior arm muscles like the triceps brachii, the posterior forearm muscles, and it gets sensory input from the posterior arm and forearm and the dorsolateral hand. Ulnar nerve is to the anterior forearm muscles with most intrinsic hand muscles, with then sensory input from the palmar and the dorsal aspect of 2 medial fingers. So here we have our brachial plexus. Let's zoom in a little bit, I guess, here, make it easier for us. So here, say our anterior rami, C5, C6, C7, C8, and T1. C5, C6, C7, C8, and T1. Okay, and that the trunks is going to blue one here, the light blue here. It's going to be our trunk superior, middle, and inferior, right? See here, inferior trunk, middle trunk, superior trunk. Kind of nice to be able to go have a nice little key for it they gave us on this one here. Our posterior divisions, our anterior divisions here, basically in the green, right? And our posterior divisions, the purple. And the chords, the posterior, lateral, and medial, dark blue here. We got our lateral. We got our, really showing it to us here, the posterior, there we go, the posterior chord here, showing you from this direction here, and our lateral pectoral nerve here, lateral cord, posterior cord, or medial cord. And of course our terminal branches, where it ends out here, the musculocutaneous nerve here, our median nerve here, our ulnar nerve here, axillary nerve, and our radial nerve. And with the right upper limb, the anterior view, so basic anatomy, kind of going back to some of our bones a little bit here in addition to our nerves here. Our clavicle here, right? And there's a lateral cord, and our posterior cord, and our medial cord. We have our axillary nerve, innervating that upper arm here. And we have our biceps brachii, being one of our big ones there. Our musculocutaneous nerve here, humerus bone here. Our radial nerve, ulnar nerve, ulna being the inside, or if you're looking at anatomical position here with your palm facing open, we have the ulnar nerve here for the ulna on this side here, and the median nerve traveling through, not to be confused with medial here, but the radial nerve here on the radius side, specifically going more toward of course, the radius on the side of the thumb side on this side. Then we have our superficial branch of our radial nerve coming through, the ulna, below basically one of our forearm bones, right? The larger of the two, and the radius being here. And here's our median nerve here, traveling right down our middle here, the median, right? And our recurrent branch of our median nerve, the deep branch of our median nerve, or ulnar nerve, excuse me, superficial branch of our ulnar nerve, the digital branch of our ulnar nerve, the digital branch of our median nerve here, ending there. So the brachial plexus injuries you might see would be minor injuries that are often treated with rest. Severe injuries, however, can require nerve grafts or transfers. Axillary nerve injury can be compressed by the axilla or in the axilla, or damaged if the neck of the humerus is broken. There's difficulty abducting the arm, bringing the arm out to your side, and anesthesia along the superlateral skin, so you actually can't feel things in that area. The radial nerve injury is by the humeral shaft fractures or injuries of the lateral elbow. It causes paralysis of the extensor muscles of the forearm, the wrist, and the fingers, and it causes anesthesia along the posterior arm, forearm, and part of the hand. Posterior cord, axillary and the radial nerves injury may be injured by improper use of crutches, like crutch palsy. That happens as well. And median nerve injury as well can be compressed in the carpal tunnel syndrome, which is obviously what people get when they get carpal tunnel problems. It causes paralysis of the thinner muscles, the lateral lumbricals, and gets anesthesia in the part of the hand where you can't feel things, right? Ulnar nerve injury can be injured by fractures or dislocations of elbow. It causes paralysis of most intrinsic hand muscles, sensory loss on the medial hand. Superior trunk C5 to C6 injury is injured by excessive separation of the neck and the shoulder. Any brachial plexus branch that has these nerves is affected. And the inferior trunk injury can be injured if the arm is excessively abducted, bringing it out to the side too far, coming up. Any brachial plexus branch from these nerves is affected to some degree. So our lumbar plexuses, we're going down that spine, and all the innervations we get from that area, these nerves. Lumbar plexus is from anterior rami of L1 to L4. The femoral nerve is the main, we've heard about this one, we hear about the femoral artery a lot. Femoral nerve plays a great role too. The main nerve in the posterior division of the plexus. It innervates anterior thigh muscles and the sartorius. It gets sensory input from the anterior and the inferior medial thigh and the medial leg. And basically the obturator nerve, we're talking about the main nerve in the anterior division of the plexus, innervates the medial thigh muscles. Basically you're talking about the hip, essentially, right? We say thigh, they say thigh, the translation would also be hip, and the leg would refer to more like knee, okay? And it innervates the medial thigh muscles, sensory input from the superior middle skin of the thigh. Smaller nerves of the lumbar plexus innervate the abdominal wall and portions of the external genitalia. So here we have our lumbar plexus. So orange being our anterior rami, our posterior divisions here in kind of a cream color, and anterior divisions of blue. So we have our rami, which are L1, 2, 3, 4, and 5. Then we have showing our posterior divisions here of our iliohypogastric nerve, our ilioinguinal nerve, our lateral femoral cutaneous nerve, our femoral nerve, and those are all our posterior divisions. And our anterior divisions, right? We have our genitofemoral nerve, and we have our obturator nerve. Those are two that are shown for our anterior. And our right lower limb anterior view. So then we have our iliohypogastric nerve, our ilioinguinal nerve, a genitofemoral nerve, traveling through here, and our femoral nerve, the large one here emanating out, the lateral femoral cutaneous nerve, obturator nerve, which again began up here, down through here. And our saphenous nerve, showing you here, actually having branched out from the femoral nerve and coming down all along here. Our sacral plexuses are the anterior rami of L4 to S4. The anterior division nerves tend to innervate the flexor muscles. The posterior division nerves tend to innervate extensor muscles. The sciatic nerve is the largest and longest nerve in the body. It's formed from portions of the anterior and the posterior sacral plexus. It's composed of the tibial division and the common fibular division. The two divisions split into two separate nerves just above the popliteal fossa. And you got our tibial nerve for the anterior division of the sciatic. It innervates the hamstrings and hamstring part of the adductor magnus muscle. It splits in the lateral and medial plantar nerves that innervate the plantar muscle of the foot, and it receives sensory signals from the skin on the sole of the foot. And then the common fibular nerve innervates the short head of the biceps femoris muscle, and splits into deep fibular nerve and superficial fibular nerves. Then we have our deep fibular nerve, which innervates the anterior leg muscles and muscles on the dorsum of the foot, and the sensory input from the skin between the dorsum of the first and second toes, and the superficial fibular nerve, which innervates the lateral compartment muscles of the leg, and sensory input from the dorsal foot and the anterior inferior leg. So we have our sacral plexus here. We have again our anterior rami in orange once again, posterior divisions in cream color, anterior divisions in blue. So we have our anterior rami of L4, L5, S1 to S4. Okay. We have our superior gluteal nerve here emanating out basically from our L4, our L5, and our S1. And our inferior gluteal nerve, the glutes, we have coming also emanating out here from L5, right? S1 and S2. And we have the nerve of the piriformis, hip muscles that also plays a role in rotation. And that's coming out from basically S2 and S1. Our sciatic nerve, when people get that sciatic pain, often from sitting in a hip flex position and putting pressure there for significant periods of time, the most common way that happens. We have a common fibular division here, which is actually getting innervation there from L4, L5, S1, S2, all throughout there. And our tibial division here, more from the anterior portion there, coming out also from L4, L5, S1, S2, and S3. Okay. And our posterior femoral cutaneous nerve, which is really coming mostly from S1, but also from S3. And a pudendal nerve here from S2 and S4. So we can see then, here's our superior gluteal nerve, obviously innervating the glutes here, hip muscles here, the inferior gluteal nerve here, our pudendal nerve, which is essentially going to come down through here and affect muscles of the hip there. And our sciatic nerve, which plays a role significantly with the hamstrings and with the hip, with the hip muscles as well as those hamstring muscles playing a role too. And then we have our posterior femoral cutaneous nerve coming all the way through here. Common fibular nerve here, obviously playing a role with movement there at the fibula there. The tibial nerve, going to play a role with motions at the foot here. Our sural nerve as well. And our medial plantar nerve ending here, and our lateral plantar nerve here. Now for sacral plexus injuries, superior and inferior gluteal nerves can be injured by poorly placed gluteal injection. So if someone gets an injection there, and that can cause some serious problems with sacral plexus. A sciatica is injury to the sciatic nerves, we briefly mentioned. It's characterized by extreme pain down the posterior thigh, from more to the hip and leg, knee, okay, down basically entire leg, can radiate down. Can be caused by herniated invertebral disc, can be a disc problem. It also can be related to more just muscles of the hip, not necessarily just the disc, but that can be related to the disc. Common fibular nerve, it's prone to injury due to the fracture of neck or compression from the cast, can cause paralysis of the anterior and lateral leg muscles, and the person is unable to dorsiflex and evert their foot. So what did you learn? What are the differences between an anterior ramus or ramus and posterior ramus of a typical spinal nerve? What's a dermatome and why may a dermatome be clinically significant? What's the composition of a typical nerve plexus? In general, what do these intercostal nerves innervate? And what's the action of the phrenic nerve? What spinal nerves typically compose a brachial plexus? Which nerve might you have damaged if you have difficulty abducting your arm and have anesthesia or lack of sensation along the superlateral arm? And how do the ulnar nerve and radial nerve compare with respect to motor and cutaneous innervation? Which nerve of the lumbar plexus might you have damaged if you have difficulty extending your knee? What anterior rami form the sacral nerve plexus? And what general areas of the body does it innervate? And then we'll come back to reflexes, our final section, because 14.7 is short, and we're actually not going to talk about some of the neural aspects there, which we'll refer to when we get there shortly. But reflexes will be our last portion for chapter 14, coming up here shortly.